Good morning, everyone, and welcome to the second day of the IASP COVID chronic pain seminars. I'm Dr. Hans Clark. I'm a staff anesthesiologist, a clinician scientist, and a chronic pain physician, and founder of our transitional pain service here at the Toronto General Hospital in Toronto, Canada. It's my absolute pleasure to be with you this morning and moderate the Long COVID Understanding the Patient Journey and Optimizing the Treatment of Pain seminar. Today's presentation will look at the broad variety of pain syndromes experienced by patients after their COVID virus has been cleared, both transient and persistent, and their assessment, including self-diagnosis. There's no doubt that any center that has treated these patients will start to get an influx of patients that are post-COVID, and both speakers today will speak to what they have been seeing and some of the experience related to these patients in their hospital systems. So I'm going to describe both speakers. The first one is Dr. Daniel Chiampi de Andrade of the Hospital das Clínicas, and he's joining us from Sao Paulo, Brazil. Dr. Chiampi de Andrade is a neurologist specialized in pain. He is an attending physician at the Hospital das Clínicas, Sao Paulo, Brazil, where he coordinates the institution's neurology department pain center. He is also dedicated to pain research and education. He is currently the coordinator of the 12-month pain residency program for neurologists and neurosurgeons, and he is vice leader of the Medical Research Lab 62, one of the medical research groups in his institution. After Daniel's presentation, we're going to have Dr. Cesar Fernandez de las Peñas of the Universidad Rey Juan Carlos joining us from Spain. Cesar Fernandez de las Peñas has published around 500 publications, and he is the first author on approximately 140 of them. Most of his papers concentrate on clinical human pain research, drug screening, and interaction between motor control and chronic pain. The most relevant topics of his research is the focus on neck pain, headache, and neurophysiological effects of manual therapy. The research activities are concentrated on biomedical science within neuroscience. The specific research areas have been on pain and assessment of pain in volunteers and chronic pain patients. The main focus is on human clinical chronic pain research. A substantial network of international collaborations with 5 different countries has been established with universities and hospitals. He is the leader of the European study on long COVID pain and coordinating all of this from Aalborg University. So looking forward to these presentations, and we'll be sure to have a fruitful discussion at the end of this. I'm going to turn it over to the presentations at this point in time. Thanks again for joining us today.
Hello, everybody. My name is Daniel Chiampi de Andrade. I'm glad to participate on this webinar. My talk will be on de novo chronic pain as part of the post-COVID-19 syndrome, nomenclature issues, and current clinical data. These are my disclosures. Well, we've seen and we've been using several names and nomenclatures to designate patients who had COVID and remained symptomatic. The term long haul COVID has been coined in a neurology publication, and for non-native English speakers such as me, this is not so intuitive. So long haulers would mean a long way, a long path, and long haulers, people who are in this long path of disease, of getting better. So that's the main idea behind this nomenclature. And we also have several other names used by several institutions, such as post-COVID syndrome, the NHS, post-acute sequela of COVID-19, PASC, the NIH uses it, post-acute COVID, post-COVID-19 condition, the WHO uses this terminology. They prefer to use condition, not to link it to any specific disease. Long COVID, short, or late sequela of COVID-19, the CDC uses this, and chronic COVID syndrome. Well, irrespective of the name we use, there are some definitions that will help us understand what's going on. So post-acute COVID-19 would be symptoms that start after 4 weeks from the end of the acute infection. It hasn't been detected any viable replication of the virus after 3 weeks. So after 4 weeks, patients who remain symptomatic would not be still infected. We would be having complications of the infection. So post-acute COVID, 1 month after the end of the infection. And then it's subdivided into subacute COVID-19 from 1 month to up to 3 months, so 4 weeks to 12 weeks, and the term chronic COVID-19 or post-COVID syndrome for symptoms extending beyond 12 weeks from the acute infection, and most important, not attributable to other etiologies. So I like to divide the symptoms into two broad groups based on the clinical presentation from the clinical perspective. One is acute complications leading to long-term effects, acute complications that happen during the hospital stay and then may lead to sequela in the long term. We have several of these complications. One is encephalopathy, which is confusion, disorientation, agitation, and somnolence. 80% of these patients, the cause of encephalopathy is delirium, which is potentially reversible, which is different from encephalitis, which is related to altered mental status, fever, seizures, altered cerebrospinal fluid, focal findings on MRI. Hopefully, very common encephalopathy and very rare encephalitis. And stroke is also in this group. We know that patients with COVID have 1 to 3% of stroke, and it may reach 6% in ICU patients, which is 7 times higher than influenza. Patients with COVID may have, when they're still in the ICU, from 20 to 40% of these patients may have significant cardiac arrhythmias and bacteremia, which happens in 10% of patients, but when it happens, it increases the risk of a stroke by 20%. So stroke is very common, all types of strokes in patients with COVID. And we also have dysimmune post-viral disorders, such as ADEM, which is acute disseminated encephalomyelitis, necrotizing hemorrhagic encephalitis, and Guillain-Barré syndrome. All these complications are common after regular viruses such as influenza, and they have also been reported after COVID, and they may lead to sequela. Not to mention a very specific topic that will be covered in other talks, which is complications due to ICU stay related to medications, muscle blocks, muscle relaxants, and sedation and immobilization. But we also have insidious long-term complications. Well, acute complications, we're gonna have, for example, stroke in a patient with central post-stroke pain or post-stroke pain. But what about the insidious long-term complications? Here we have complications or symptoms that we will start usually slowly during the acute infection and will remain after the infection. There are some exceptions to this pattern, but that's a general pattern that we see. And some of these insidious complications are common to other viral infections. For example, Parkinsonism, depression, cognitive decline, post-traumatic stress disorder related to ICU stay, anxiety. All these complications have been reported due to other viruses infections in other scenarios, and they also occur after COVID. Even a hippocampal atrophy and cognitive decline, they have been reported for a long time. And chronic pain, so varicella zoster virus, Zika, Epstein-Barr, so post-mononucleosis syndrome, which is relatively frequent, and infectious disease specialists often see these patients. Chronic pain after influenza, or in some areas of the world, such as in Brazil, HTLV1 infection leading to chronic pain. But, so we know that pain is common. It's been shown several studies during the acute setting of COVID, from 20 to 40% of patients during the acute infection, both patients in the outpatient or inpatient settings, they will have acute pain. And several studies also confirm that after in the weeks following the infection, so in the post-COVID setting, from 20 to 30% of patients will have, in the weeks following the infection, pain. They will suffer from pain. So what about chronic pain? What about pain starting after COVID and being present most of the days and lasting more than 3 months? So one way to organize and name, we have to remember that pain is common in the general population. At least 1/5 of the general population suffer from chronic pain. So sometimes it's hard to differentiate chronic pain aggravated by COVID and de novo chronic pain due to COVID. One way to organize this idea is to have these three classifications that we are proposing. One is to name COVID-19 unrelated pain for patients who had chronic pain, for example, migraine or low back pain or fibromyalgia. They had COVID and the pain was not affected by it. These patients exist and they must be named so. Another scenario is those patients who have chronic pain and during COVID-19 infection, they have aggravation of their chronic pain. So that they have the same chronic pain. These are migraine patients who have more migraine attacks during the infection. And a different scenario is those patients who do not have chronic pain and they develop chronic pain either because they started to have acute pain during the infection and remained having chronic pain, or in some scenarios, and this is disputable and needs to be discussed, but some patients start having chronic pain or symptoms not straight after the infection, but they developed it after a few weeks or months of the infection. And that relating this scenario in this case where the COVID infection is really difficult and open to discussion. But anyway, it also happens. So we would have COVID unrelated pain, aggravated pain, and COVID-19 related pain. We will be able to classify patients using this approach. And can COVID-19 cause new pain in previously pain-free people? So if so, these are main questions. Which pain syndromes are more common? Is post-COVID pain short-lived? Can it become chronic? How can it be managed? We have questions for a few of these points, and we have answers for a few of these points, but not for all of them. We're going to see this. The first studies that came out were on headache. So we had reports two from Spain, one from Brazil, and one from France. These reports were based, most of them, on retrospective cohorts, but some of them were prospective. Most patients were interviewed by telephone, or they had their medical charts assessed, and some few were interviewed face-to-face. These studies showed several things. One is that headache can affect a significant proportion of patients, more than 50%, during the acute phase and the weeks following the acute phase. So headache is frequent during and right after COVID. And also in these studies, having headache during the acute COVID as outpatient or inpatient, some reports associated acute headache with less death, and also with anosmia. It remains to be confirmed. With more than one studies found such an association. But so far, these studies had no controls. They only assessed headache, and they did not assess patients who had symptoms beyond 3 months. So we cannot use the term chronic pain to refer to these patients. And we had no really deep information related to previous chronic pain. We don't know if these patients had chronic migraine and got worse migraine after COVID, or if they had de novo headaches after COVID. So we don't have a lot of information on the prevalence of previous chronic pain in these patients. And another question is, do post-COVID-19 symptoms last beyond 3 months? So the first large study published was from a Chinese group looking at patients, assessing by telephone or by internet, patients who had COVID and were assessed 6 months after the infection. And they classified symptoms as new symptoms if they fulfilled criteria of being newly occurring or persistent symptom, or any symptom worse than before COVID-19 development. And they had several symptoms. Usually fatigue is the number one, with dyspnea. And several of them could be related either to chronic pain or to dysautonomic symptoms. Fatigue and sleep difficulties, number one, smell disorder, and then joint pain, decreased appetite, taste disorder, dizziness, chest pain, myalgia, and headache detected in a relatively small proportion of these patients in this study, but still present and being chronic after COVID. We published a study trying to answer the question on whether we have chronic de novo pain after COVID. We compared patients during the first wave of 2019 2020 wave, and we compared them to patients who were hospitalized in the same institution in a different hospital, but they were patients without COVID. So we compared patients who had COVID with patients who were in different hospitals within the same health system without COVID during the same time. And these patients had pretty much the same profile, except for heart disease. The control group had more heart disease because it was a heart institute, and several differences related to ICU admission. Patients with COVID stayed more in the ICU, but the proportion of patients receiving mechanical ventilation was close to the control group. So these are baseline information. And patients with COVID, 10% of them had previous chronic pain. And when we looked at de novo pain, so any new pain, or in patients who had no chronic pain previously, after COVID, we found pain being significantly more commonly located on the head, legs, and being widespread in about a fourth of the patients. When we looked at the proportion, 65% of patients had new onset pain. So there were patients without chronic pain, without pain, who had new pain, compared to the control group, which was 11%. And new onset chronic pain. So several of these patients were interviewed after more than 3 months from the acute infection. And we found close to 20% of patients in the COVID group developing new pain or a new type of pain, if they had previous pain, that lasted more than 3 months. So showing that chronic pain does exist, and it would affect a significant proportion of these patients. Well, looking specifically at headache, de novo headache was presented up to close to 40% for the patients, and it was de novo chronic daily headache being presented most of the days for more than 3 months in 13% of these patients, against 0 in the control group. Well, these headaches had several characteristics similar to migraine. De novo headache had photophobia, phonophobia, osmophobia, nausea and vomiting in 27 to 40% of patients. It was frequently unilateral, pulsating, and with neck irradiation, and it was aggravated by orthostasis, Valsalva maneuver, or clinical routine physical activity in a significant proportion of patients. The patients with COVID were treated with current drugs commonly used for nociceptive pain. So they had common analgesics, NSAIDs, methimazole, which is very commonly used in Brazil, and some of them had muscle relaxants. So another question, another very important point is related to the fact that most of these studies, if not all of them, were related to symptoms. So because of the infection of the pandemic, it was really difficult to see patients face to face. So everything we know so far is related to symptoms assessed by phone interviews or questionnaires sent by email. So there's a lot of clinically relevant information that we simply don't know yet because we haven't examined these patients and published the respective data so far. I will present you some data from a clinical study we are conducting, in which we are interviewing and examining with a standardized bedside neurological examination and a few other QST assessments. We assess patients who were in or out hospital during the infection. All of them had infection, had COVID infection. They need to be interviewed after 3 months of the infection. And we are planning to assess 300 patients. And so far, I'm going to show you data from 132 patients. So what about previous chronic pain and COVID? So these are the patients who had previous chronic pain. And how did it go during the infection? So among patients who had previous chronic pain, which is 42 patients, 43, we had 65% who had aggravation of their chronic pain, 24% no change, 5% resolved, and 5% improved. So most patients with chronic pain get worse during the infection, and a few of them will not have any change in their chronic pain. Then we compared patients who had aggravation of their chronic pain, previous chronic pain, and those who did not have any aggravation. And these patients were more or less similar between them. So they had similar age, sex, percentage of hospitalization, percentage of hyposmia or hypogeusia, and fatigue. So these variables were not different between those with previous chronic pain who had aggravation versus those who did not have any aggravation of their chronic pain. Then we looked at de novo pain after COVID. So if you take all the patients we assessed, patients who had new pain comprised 52% of all the patients we interviewed. And 5% of them had this new pain already resolved by the time of the interview, and 47% had this pain persisting. So it's a new onset pain, which was persisting at the time of the interview. These patients, all of them have chronic de novo pain after COVID because they were assessed by definition after 3 months of the acute infection. And the DN4 was positive in 32%. When we compared patients with versus without new onset chronic pain, so those patients who had new pain with those who did not have new pain, we found similar age, which was about 45 years, percentage of hospitalization, about a third, previous chronic pain, which was about 30%, previous pre-COVID-19 fatigue, they had similar percentages, and time since infection, which was in average 9 months in both groups. But patients with pain, with new onset chronic pain after COVID, they were more frequently female, 81%, 71% had either hyposmia or hypogeusia, and 77% had new onset fatigue. So patients with new onset chronic pain had more fatigue, more hyposmia, and were more frequently female. And the intensity was relatively high. The average pain intensity in the last week from 0 to 10 was 6.8. And the frequency of pain was also very high. So most of the patients, about 40% of them, had pain within the last 30 days from 22 to 28 days. So pain was pretty much present every day on a single daily basis. When we looked at interference, pain interference, these patients had an average of 4 from 0 to 10 on the BPI interference scores, and they had interference in most activities from the BPI interference score. They had very impacted and negatively impacted quality of life. Their current health status from the Eurocall was very high, was 67 in average. It goes from 0 to 100. So we have as conclusions, can COVID-19 cause new pain in previously pain-free people? Well, with the data we have, yes. We have a lot of data showing that patients without chronic pain may develop new pain that quite frequently is a headache, but it may be leg pain, lasting more than 3 months and being present most of the day. And if so, which pain syndromes are more common? Well, this remains to be better explored, but so far headaches are very prevalent and patients with leg pain are being explored in this study. And we found a relatively high proportion of patients with a positive DN4. Well, the DN4 is a screening tool, but in the general population, it's about 7% positivity. So of course, this type of assessments, we have bias. Patients who had worse COVID or who are symptomatic, they tend to come more frequently to the study than those patients who have no symptoms, but still 32% is relatively high. Is post-COVID pain short-lived? Well, it may be short-lived in some patients. We saw that 5% of our sample resolved, had the post-COVID pain resolved when assessed at an average of 9 months, but most patients remain symptomatic. But it may be short-lived. Can it become chronic? Yes, it can. And how can it be managed? Well, this is a pending issue, which will be very linked to the answer of item related to the syndromes that we will most frequently find. So this is something that we cannot answer so far. So currently we have a lot of questions, some answers. We are optimistic to have more answers in the near future. I would like to thank you for your attention, and the references that I use can be found using this QR code. Thank you so much.
Hello, everyone. My name is Cesar Fernández de las Peñas. I'm a physical therapist from Spain. I would like to thank to the PSPA for inviting me to this section and talking about musculoskeletal pain and COVID-19. So it's sad that we cannot share personally this time because the situation of the outbreak, but I hope that we can share this info for the patient with COVID-19. So the first thing is that I think that we don't need to say nothing about what is the situation today or has been the last year for the COVID-19 outbreak. We have a pandemic, we have a crisis, and we have many millions of deaths. However, important thing that we will discuss today is that we have more than 200 million of COVID-19 survivors. What is meaning? That we are now in front of a second pandemic, that it will be the post-COVID symptoms, or that we have been called the long COVID. This lecture will discuss the presence of musculoskeletal pain in post-COVID symptoms, and we will discuss first if this condition, if the long COVID is a reality or is a fiction. So what is long COVID? I think that is highly increased or is huge the number of publications, thousands and thousands of publications in the last year about COVID-19 and also about complication or post-COVID-19. There are many systematic reviews, many meta-analyses discussing the prevalence of different post-COVID symptoms. The first message to say is that the presence of long COVID symptoms is not related to the severity of COVID-19. Asymptomatic people, people with severe COVID-19 or with mild COVID-19 can be developed with the same proportion different post-COVID symptoms. I would like to show you what is the most prevalent post-COVID symptom, and we know today that the fatigue and the dyspnea are probably the most frequent conditions. However, we will discuss the third one, that is the pain, musculoskeletal pain, or the myalgia post-COVID. Briefly, I think that we need to distinguish between people that has been in the hospital because the COVID-19 and people that has been not at the hospital that maybe can be asymptomatic or just with a minimal COVID symptoms. I would like to share you what is the first point or the time point that we are now about the post-COVID prevalence. The first systematic review meta-analysis was this one, that they demonstrate that there are almost around 60% of people suffering fatigue, almost 20% with joint pain, 11% with pain in general, and 44% with headache. However, what is the main problem with this meta-analysis is that these prevalence dates did not differentiate between people at the hospital or people at not hospital. They didn't differentiate at which follow-up period the symptoms appear. So we have just one prevalence. Many systematic review meta-analysis has made the same mistake. They say that the prevalence, for example, in this one of fatigue, the prevalence is almost 50%. But the question is, in this case, they say that only people that has been at hospital, but the question is, okay, this prevalence is 1 month, 2 months, 3 months, 4, 5, 6 after the COVID. The same problem with other systematic reviews. The only good thing is that we have improved, and now they make the distinction between people without hospital and people at hospital. And we will start to focus on the musculoskeletal pain symptoms. Other terms that have been used is post-COVID, post-acute COVID, chronic COVID. So now we need to discuss. This meta-analysis includes one important thing, the difference on the time set, on the time frame. Okay, acute post-COVID or chronic post-COVID. The symptoms can be slightly different. So we have started from a global prevalence rate in the first meta-analysis. Now we are in meta-analysis saying the prevalence is different between people at the hospital or not hospital, and also when they are acute post-COVID symptoms the first 2-3 months after the infection, or chronic post-COVID symptoms more than 3 months after the infection. So we have a roller coaster situation of post-COVID. The prevalence of post-COVID symptoms, it will be sure that it will be not the same at 1 month, 2, 3, 4, 5, 6. So we have roller coaster that are increase and decrease in the prevalence of post-COVID symptoms. In fact, this has been confirmed in some recent studies, looking that there are 3 different clusters of patients. There are cluster 1, that there are acute onset, so there are huge increase of post-COVID symptoms, very quick after the infection. There are people that they are stable post-COVID, so they have the same symptoms from the beginning and during the year. And there are the cluster 3, that is the roller coaster post-COVID symptoms. There are people that have symptoms 1 month, the symptoms disappear or increase, improve. 2 months after, increase again. So there is a roller coaster cluster. We made a meta-analysis including all these topics. We make the distinction between acute and chronic, and which follow-up period the symptoms appear, and making the distinction between hospitalized patients and non-hospitalized patients. What we found, we have seen that the roller coaster is highly important. It's highly important to see in which time frame or time course the post-COVID symptoms appears. For example, here we see a baseline for fatigue. This is the baseline, the onset symptoms on the fatigue that the patient present at hospital admission or at the onset of the infection. We can see that the symptoms 30 days after, so acute, post-acute COVID symptoms are few. There is a huge increase 60 days after, and there is again a decrease on 19 days after. We have only at this time prevalence data until 3 months after. We can see that is highly important. And the tendency between people at hospital and not hospital are the same. So what is post-COVID? What is long COVID? What is acute post-COVID? What is chronic post-COVID? What is persistent post-COVID? We have many papers about the definition. There is no clear definition today. There are scoping reviews discussing the criteria that we need to understand the post-COVID symptoms. We need to differentiate. And we will try to do this and to make a proposal for musculoskeletal post-COVID pain symptoms. We have here many different things to discussing. At the beginning of the pandemic, Klaus said that we need to understand that chronic pain will increase with the COVID-19 outbreak. This will be clear, and we have seen that this is the reality. There are many mechanisms, many actions that the COVID-19 can improve or can increase musculoskeletal pain symptoms. Why? For example, the first theoretical aspect is we know the cytokine storm that the COVID-19 infection provoke. So we know that the cytokines are highly pro-inflammatory mediators. We know now that there is an interleukin also storm. So we have 2 storms, cytokine and interleukin storm, that this is the perfect storm for developing pain symptoms. Obviously, there are many other theoretical aspects. For example, we know that the receptor that the COVID-19 goes into the body, the AC2 receptor, is present in highly in many systems. And interestingly, the muscle, the musculoskeletal system, is the system of the body with a higher density of AC2. We can see that the muscle has AC2 receptors. The cartilage has also high density of A2 receptors. And also the synovium. We can see in comparison with, for example, the airway, that is the mechanism of transmission. Also, the TMPRSS2 receptor also has highly density on musculoskeletal conditions. So in the musculoskeletal system, muscle, cartilage, meniscus, synovium. So this is one reason why the COVID-19 virus can also affect or can promote musculoskeletal pain. However, what situations or how many situations can we find with patients with chronic pain? First, people with chronic pain that they are not infected by COVID-19, so the negative people. So there are people with previous musculoskeletal pain. Okay, we will discuss what happened with this patient. The outbreak of the COVID-19 has also different repercussions on people that are not infected. Obviously, what happened with people that is infected by COVID-19. Also, we need to understand that it's not the same either negative or positive that have previous musculoskeletal pain conditions, pre-existing musculoskeletal pain conditions, or they are pain-free before the outbreak. And also, a topic for discussing is the presence of the symptoms at the onset, because today we are seeing that one of the most important risk factors for developing long COVID is the onset of COVID-19, the symptoms that the patient have during the infection. And we will discuss this. So we will start with people with chronic pain before the outbreak, that they have never been infected, but they have chronic pain. What happened? Many studies demonstrated that the intensity, the severity, and the health-related quality of life of people with chronic pain without being infected by COVID-19 has increased. So the COVID-19 outbreak promote, not by the infection, but the different circumstances, what we like to call the COVID-associated factors, chronic pain. For example, isolation of the patients, the outbreak, the close of the world during the March 2020. Fear, sleep disorders, anxiety, always catastrophic news, physical activity, all are factors that has increased the prevalence of chronic musculoskeletal pain in patients not infected by COVID-19. So we have the first repercussion of COVID-19 outbreak, an increase of chronic pain in people not infected. Now, what happened with people that has been infected? Obviously, there are some studies focusing on just the pain symptom as post-COVID sequela. In this case, there are few studies. We need to recognize that the pain symptom has been not investigated at other as fatigue, dyspnea. There are only just few studies focusing only on musculoskeletal post-COVID pain. In this case, these authors see 1 month after the infection, so it's only post-acute, but at least some data, saying that almost 80% of patients that have been infected by COVID-19 exhibit any musculoskeletal symptom the month or 30 days after the infection. So the presence of musculoskeletal post-COVID pain symptoms is highly prevalent. There are just only one study analyzing the prevalence of new onset pain because the infection, and they see that patients that have been infected by COVID develop headache and develop mostly lower extremity symptoms. Obviously, there are different places of pain, but we can see that the prevalence of de novo pain, so new onset symptoms that we will discuss in a minute, is almost 65%, at least 30, 45 days. Again, this study is a short period of time, and this is why it's important at the beginning of the lecture, the moment of the follow-up where the symptoms appear, that the prevalence of musculoskeletal pain or new musculoskeletal pain is highly important. We have a meta-analysis under review in a journal making the analyzing the time course of the musculoskeletal pain symptoms, and we have included or improved the first meta-analysis. We assess only musculoskeletal pain symptoms, in this case myalgia, musculoskeletal pain, joint pain, and chest pain. And we assess the total and between hospitalized and non-hospitalized patients at baseline, onset or hospital admission, 30, 60, 90, and 180 days. So we have now longer follow-up periods. And we can see the same roller coaster than before. At onset, there are many people with musculoskeletal pain. During infection, a huge decrease 30 days after, an increase 60, 19, but a decrease at 180. Again, the roller coaster. Again, the importance of the relevance of assessing when the symptoms appear. And now we can see this line is highly important because we can see that there are a small number of patients, 5-6% of patients, that always will report the pain symptoms from the beginning of the infection. This will be that we need to call persistent symptom. There is a symptoms that appear at the infection and never disappears. The remaining people can be symptoms, asymptomatic, again symptoms, symptoms, asymptomatic. So this is more roller coaster, but there is just not more than 5-6% of patients with total persistent post-COVID. We will call now the proposal. Now we were really interested in know this condition. So people who have exhibit musculoskeletal pain, so myalgias, as symptoms during the COVID infection are more at a risk or a higher risk of developing musculoskeletal post-COVID pain. We published a study in the Pain Journal about myalgia as a symptom of hospital admission, so only at the hospital, that is associated with persistent musculoskeletal pain 7 months after the infection. We get a group with myalgia at the onset of infection and people without myalgia, musculoskeletal pain. People with myalgia during the infection get a higher proportion, autorated of 1.4 of developing musculoskeletal post-COVID symptoms. So this will be the people with really persistent post-COVID, people that start in the day 1, 2, 3 of the infection with asymptoms and the symptom never disappear. So suffering this particular symptom, pain during the infection, is a risk factor for developing musculoskeletal post-COVID pain. Obviously, it's not the only one. People without myalgia at the infection obviously can also develop as post-COVID. But we cannot call persistent because they didn't have the symptom during the infection. Now we will make the proposal. Another piece of the pathway. What happened with people that have chronic pain before the infection? We have seen that people not infected also increase the pain, but people that are infected, what happened with this? Is the previous history of musculoskeletal pain a risk factor for developing more musculoskeletal pain? There is only just one case series saying that there are two situations. One, that people with previous musculoskeletal pain, the COVID infection increase the pain. There is a exacerbation of the symptoms, but the same symptoms that they had before. So there are no new onset pain symptoms. And there are people with musculoskeletal pain that develop new musculoskeletal pain symptoms. So after the infection, so they have another type of pain. So we need to make this clear distinction, and now we will make a proposal for this definition. So with this data about pain, we want to show two pain models that we published the last month, discussing the relevance of time frame and the relevance of the presence or not presence or absence of symptoms before the infection. In this model, we make the integrative post-COVID symptom model, saying that depending on the time when the symptoms appear, we need to call different things. Now, this proposal was published 1 year ago, at the beginning of 2021. Now we have more data, and now we will discuss, or we will make some changes in the names, but the time frame is the same. We have hospitalization or asymptomatic people. We have the infection. The people is at hospital discharge, going outside. Can we say from now that any symptoms that appear after the patient is going out of the hospital is post-COVID? For me, no. I think that we need a transition phase. Symptoms potentially associated with COVID infection or SARS-CoV-2 infection. 1 month, because the hospital has complications. We need more than 2 weeks that the infections is really important to say that the symptoms are post-COVID. So the definition usually has been defined that post-COVID has been defined as symptoms that persist for more than 2 weeks during the infection, because it is considered that the COVID infection has 2 weeks of duration. How many patients, how many people has been at the hospital more than 2 weeks? So I think that we need a transition phase for recovery. We call transition phase 4 weeks, 4-5 weeks after hospital discharge. And now we can see phase 1, 2, 3, the first 7 weeks after the first, so the first 3 months can be acute post-COVID symptoms. And after 12 weeks, we will call long COVID or persistent or chronic post-COVID symptoms. Today, we will call chronic post-COVID. It's the same definition that acute pain or chronic pain. Less than 3 months, 4 than 3 months, but we have included the transition phase. Why? Because long post-COVID maybe can be the condition, and acute or chronic maybe can subtypes of condition. But we will develop future models. The second model was published some months ago, is related to the symptom. We have 3 different situations that have been discussed in the lecture. What is the pre-COVID status? Oops. There is a comorbidity, yes or no? It's not the same thing a patient with migraine that is infected by COVID-19 and develop more migraine or new headache. People without any comorbidity, without migraine, that develop migraine after the COVID. Pre-COVID status. Acute COVID status. The patient has these symptoms at the acute phase, musculoskeletal pain or not. If not, we need to see what will happen if there is a delay onset. So, for example, the patient starts with chronic pain, with pain symptoms 1 month after the infection, or it is persistent. So the patient has musculoskeletal pain during infection and never has disappeared the symptom. And this is the 5–6% of the patients in the meta-analysis that we have seen that always will have symptoms from the onset of the infection until the end. So we need to be clearly with pre-COVID status, acute COVID status, and post-COVID status. And we need to understand the roller coaster situation. The symptoms is a dynamic, can be fluctuating, can be progressive, can be continuous. It's the same clusters that has been recently published. So we can see that our model has been validated and proposed by other authors in posterior studies. So what will be the integrative model that we want to propose for post-COVID pain? 2 situations. Patient with musculoskeletal pain before the infection. 2 situations. This patient is infected. Okay, has myalgia during the infection or not? If not, can be only new onset post-COVID musculoskeletal pain, or has myalgia. I need to understand, okay, myalgia has aggravated the symptoms, so the patient has a musculoskeletal pain condition before the infection, and these symptoms increase, so are aggravated, but are the same symptoms that they had before, or there are new onset of post-COVID musculoskeletal pain. What is the meaning? People that develop another symptoms in addition to the before symptoms. And these symptoms can be persistent if they are from the beginning, or can be with a delay onset. That is that they have a weeks, month, we don't know, period without pain. What happens with patient that has no musculoskeletal pain before the infection or has any medical comorbidity that not share any symptom with COVID? For example, diabetes, that is a risk factor for the severity, but not for the symptoms. So I have no pain before the infection, I'm infected. Okay, the next question. I have myalgia or no myalgia at the onset? No, the only thing that I can develop now is new onset post-COVID symptoms, because I cannot get aggravated because I didn't have musculoskeletal pain before the infection. So we need to understand. And now, again, patient with myalgia onset is persistent or delay onset. Usually it will be persistent. No myalgia, it will be delay onset if present. Can be both, yes, because there is a fluctuating. So if there is a delay onset, it will be not persistent because there is no onset. For example, no myalgia onset never can be persistent. Myalgia can be never delayed. Yes or no? Can be, but it will be not proper definition because I have symptoms, I'm pain-free, and now again develop the same symptom that I have during infection. It will be fluctuating or remitting symptoms. We can call persistent remitting symptoms. We will be here. So we need to understand the pre-COVID situation, the acute COVID situation, and the post-COVID situation. So this will be the integrative model. All this model, I'm finishing. It will be related to COVID biological factors, severity, cytokines, and interleukins storm, individual factors, genetics, psychosocial factors, stress, anxiety, depression, sleep disorders, and obviously hospitalization factors. If I'm in the intensive care unit, longer stance, I have more, less severity, biomarkers, anything. So in this model, we need to understand these other 4 factors for promoting or developing musculoskeletal post-COVID pain. Thank you very much for your attention. I hope that we can better understand the musculoskeletal pain situation and COVID-19. Thank you very much.
So welcome back, everyone. First of all, I want to take this opportunity to thank both Daniel and Cesar. They're really leading the path in terms of collecting data and putting out information related to these COVID patients and their pain journey in particular. It's clearly going to become an increasing issue in the pain world, and how we deal with these patients is really going to be something we grapple with over the next years. We're now, in the Delta variant and then the Kappa variant. Who knows where we're going to land? So a couple of thoughts came to mind. Please put your questions into the question box, and we'll be fielding those as we go along. The first thing I wanted to talk about in terms of the complexity of some of these patients' presentation, and maybe I'll start with you, Daniel. Sometimes when we see some of these patients, beyond some of the MSK issues that Cesar talked about, and the complex, there's a lot of cognitive stuff going on, and you're a neurologist. Are you seeing other things? I've seen things like dysautonomia and POTS symptoms and things of that nature. I'm wondering if you're seeing that from the neurology perspective.
Yeah. So most of what I'm going to talk about is based on clinical experience. We don't have a lot of data backing up, although there is some pathophysiological basis. What we see is very frequent dysautonomic symptoms, much more frequent than we see after other viral infections. We know that some patients will have, for example, dropping blood pressure when they're standing up with orthostatic hypotension, a blood drop of systolic blood pressure for at least 20 millimeters of mercury. And some patients have symptoms, and some patients do not have classical symptoms of dysautonomia. They would just, and we know there is a large literature on Parkinson's disease. Several patients with Parkinson's disease have dysautonomia. There are some patients who do not have classic symptoms of presyncope, faint symptoms. They don't say anything about it, but they may have cognitive decline. Well, cognitive alterations are very broad and have been described in several types of cognitive dysfunction after COVID, but it's clear that some patients have cognitive abnormalities that may be improved when you treat orthostatic hypotension. There's some classical studies from Roy Freeman's group in Parkinson's disease saying that, for example, patients with dysautonomia, when they're laying down, they do a cognitive test and they have a certain score. And when you put them heads up and they stay up, orthostatic, standing up for 2 minutes, and they do the same types of tests, they have a decrease in scores. And if you do a Doppler measurement of the blood flux, you're going to see that there's abnormalities going on, and there's a relationship between these autonomic symptoms and cognitive alterations. This is probably not the only issue related, but we see in clinical practice that when we treat these patients, they do better cognitively. And the cognitive decline is, people complain about memory, but for the neurologist, we make a big difference between memory per se and this executive dysfunction. So patients actually, we use of executive functions to retrieve memories, not to create memories. And patients who are depressed, who have chronic pain or are facing dysautonomia, usually they have this executive profile of having a hard time not creating new memories, but retrieving memories that they already stored. So it's more or less what we see in this patient. And some patients, there's also from the Parkinson's literature something called coat hanger headache, which is like a cervicogenic headache, but usually located in the neck over the trapezium, that occurs when you have dysautonomia, when you have orthostatic hypotension. In some patients with post-COVID headache, and when they have orthostatic hypotension and you treat it, they may do better cognitively, and they may have improvement in headache too. There are two things that are very clear when we examine patients and see them as a clinician.
Thanks, Daniel. Cesar, I mean, when you present your data in terms of the persistence and the transition to the long COVID, you highlight a lot of things. You know, my area is that kind of post-surgical transitional pain setting, but you talk about sleep, you talk about catastrophizing, anxiety, all of these kind of cofactors that lead to people who persist in their pain. And it seems like the most one of the most predictive factors were obviously somebody who had a myalgia before they landed in the hospital with COVID. And so, you know, thinking about that, they seem pretty similar, but potentially completely different pathophysiology. So I don't know if you have any comments about what you think is going on.
Yeah, I think that we are in a front of a different virus, because we can see that the COVID-19 can be affect any system. I think that is the first one that we are in front of. And I think that we need to understand, or I think that today, the higher risk factor for developing any post-COVID symptom is to have suffered this symptom at the onset of the infection. Now we have, for example, published that people that at the beginning of the infection has gastrointestinal problems, they develop more gastrointestinal post-COVID problems, although there are a small percentage. It's the same thing that we have published with myalgia. People with myalgia as symptom, like a flu, who has not experienced sometimes a myalgia during a flu, is a higher risk factor for developing musculoskeletal pain. Probably we'll have the same thing with headache, that people that experience headache at the COVID onset probably will be a higher risk for the post-COVID headache. However, I think that at least in Spain, the term of long COVID or persistent long COVID has been used like if they are synonymous, but they are not synonymous, because I think that today the long COVID will be the condition, is the symptoms after COVID infection. But now we need to understand that there are many things or many subgroup of patients. It's not the same thing, for example, as Daniel has said, people with cognitive blurring, that they have cognitive problems only. There are no others, not other symptoms, you know, they have only neurological symptoms. It's not the same thing that people with tachycardia. It's not the same people with gastrointestinal problems. It's not the same with fatigue or lung problems. It's not the same that people with just musculoskeletal neuropathic pain problems. I think that we need to understand in the mechanisms that you have asked, that one thing is the symptoms without a clear tissue damage, for example, musculoskeletal pain, and for example, Parkinson's disease after COVID-19, that there is a tissue lesion or tissue damage. I think that we need to understand post-COVID symptoms is not the same that post-COVID sequela. The post-COVID sequela, for example, is the damage that any tissue has after the COVID. There are 15% of patients with lung damage 6 months after the infection. But this lung damage doesn't explain the fatigue in 60% of the patient, because 45% of the patient doesn't have any tissue damage. So I think that we need to be very precise in front of the terms of the definition, in front of which kind of patient we are in front of. Because, for example, we have some patients at our clinic with being infected with the SARS-CoV-1, with the SARS, and they have clearly destroyed the lungs, but they don't have any respiratory symptoms, but they have tissue scars, fibrosis, the lung, they are destroyed with the first SARS, but they have no symptoms in the fatigue and respiratory system. So why? So I think that we need to understand that the mechanisms are probably more complex than we believe. So for example, and in the question about the mechanisms of persistent musculoskeletal pain and roller coaster, what we call musculoskeletal pain, probably will be that, my opinion, is that the infection open the pathway for the symptoms that they will develop. For example, if I'm a biological at a risk factor for developing musculoskeletal pain and I'm being infected by the COVID, probably I will get musculoskeletal pain as onset symptom. We don't know why. Genetics, catastrophizing, my anxiety, my stress, my trait, my thinking, my belief, my previous experience, anything, and the cytokine storm and the interleukin storms promote the pathway for this way. For example, anosmia, ageusia, has been demonstrated that they represent invasion of the central nervous system. anosmia and ageusia are highly correlated with post-COVID headache because they are into the central nervous system. So we think that it will depend where the infection is more aggressive or affected, the patients will develop this or this post-COVID symptom.
Thank you, Cesar. So very comprehensive answer there, but it's certainly stimulated a plethora of questions. So I'm going to start tackling the questions that are coming in. The first question came in from Nadine, actually, and she said, great talks. And I have to say, this question strikes a chord because one of the hats I also wear is an Ehlers-Danlos syndrome clinic. And many of these young women in particular will tell you that they had a viral illness that started some of these neurologic symptoms. And ever since this viral illness has happened, and we're talking pre-COVID, obviously, they've not been able to be back to normal. But test after test come back with completely normal neurologic testing. So the question from Nadine is, have you seen patients with post-acute symptoms, including pain, without neurological symptoms, despite being with neurologic symptoms, despite being asymptomatic at the time of testing? And I guess, Daniel, you can start with this one, and Cesar can jump in if he likes.
In this cohort, we have some patients who they don't even know exactly when they got COVID. They were tested randomly to travel, for example. They had no symptoms, but they developed symptoms afterward. Then there's this very gray area. Would these patients develop any type of symptoms after anyway? Was it related to the infection or the presence of the virus? That's open to discussion. Well, just one thing that Cesar mentioned that I think it's extremely important, and we as a pain community, we need to really maybe focus on it, is to worry about wording and choose very wisely the words that we're going to use for each situation, because we try to differentiate all these instances. Patients who have no acute symptoms and develop symptoms afterward, how would we classify these patients who had aggravation? And I think that's very important. But yes, we do have these patients who get symptoms afterward, but then it's open to a certain whether these symptoms are actually related to COVID or it would just be the normal incidence of new onset chronic pain in the general population. It's open to questions.
Right. Okay.
Yeah, I think, for example, I have one patient that today we don't know if it is really post-COVID, but that she doesn't remember that she has COVID because, many people are asymptomatic. That she started with a musculoskeletal pain syndrome like plantar fasciitis. She has a huge inflammatory reaction, and she has the plantar fascia of 10 millimeters. That is more than 4 times the regular thickness. And now she developed a neuropathic pain component. So, and unilateral, now bilateral. And this is why we ask, or we suspect that this is not the regular pain pattern from musculoskeletal pain to neuropathic pain with neurological symptoms. He has started with, she has lost the reflexes. So she has developed a neuropathic component without any reason in 2 weeks. So we don't know if it will be the COVID. We don't know because she doesn't remember that she has COVID, but there is no other explanation. So we have 5 neurologists working together with me and other radiologists, and nobody find any reason. Now the problem is that I think, I always say that we need to be very, prudent, because we are in the same way that in fibromyalgia 30 years ago. Not all today is post-COVID. So we are in front of people that we will say, oh no, this is COVID, this is nothing. So we can get it like a bull tux, a tux ball, that no, all is post-COVID. I think that we need to be very slow saying, okay, we don't know. There are many people, at least in the first outbreak, that was not diagnosed. Probably they will get it. They will start with symptoms. And we need to be very prudent. For example, I have another patient that she has pro-inflammatory arthritis after COVID. She was diagnosed of COVID, and 3 months after, she was okay. But 3 months after, she started with a huge pro-inflammatory process in all the body. And each 2-3 weeks, she has highly graded trochanteritis pain, bilateral. She's in bed. So it's like we believe that the COVID-19 has initiated or promote a pro-inflammatory arthritis that it was, sleeping in this body. So we don't know we are in front of a new age that we will need many years for understanding.
Okay, so Cesar, I'm going to move to the next question because I think it ties into some of what you're saying. Some of what you're saying here. So we have a question from Stephanie Golick, and she's a PhD, a PharmD from Sonoma, California. And so she was wondering, in particular, you're talking a lot about, fibromyalgia, fatigue, myalgias. So would you classify the post-COVID, or question is, would you classify the post-COVID fatigue myalgias as fibromyalgia? And have you found any specific medications, I guess it goes to both of you, to be helpful? So she's asking in particular low-dose naltrexone, duloxetine, SNRIs. And she's very thankful for the presentation. So, how do you start to treat some of these, post-COVID myalgias and kind of fibromyalgia-like presentations? Whoever wants to start, go ahead.
Clinical practice, what I do is, of course, it's not really evidence-based. I would say that it's pathophysiological based, but what I do is try to see if this patient does not have a previous chronic pain that was aggravated, something that I see quite frequently. For example, are patients with migraine who are not having a lot of migraines recently, but they are a migrainer. And after COVID, they take a lot of NSAIDs, they take a lot of analgesics, and they develop medication overuse headache. In my clinical practice, probably biased because I'm a neurologist, this is extremely common. So I wouldn't say that it's, of course, COVID may trigger headaches that look like migraine from the clinical perspective, but some patients simply come overusing medication, and I would treat them as I would normally treat patients with overuse medication and headache related to it. If the patient has a normal de novo chronic pain after COVID, I would treat it symptomatically using the current classifications and guidelines. We can call somebody from the syndromic perspective with symptoms of fulfilling the criteria for fibromyalgia, even if it's comorbid and related to COVID, we can call it fibromyalgia. And I've been treating these patients based on the syndrome, doing a lot of rehabilitation and using medication as I would normally do to patients with fibromyalgia, for example, not related to COVID. In my practice, I would say that the number one is headache. Most frequently, medication overuse headache after COVID. The patient comes already using a lot of medication. I don't know if it's the same thing in Spain, Cesar. And musculoskeletal pain, and this, in our small study, we had a fourth of patients with diffuse pain, and see a lot of these patients who look like fibromyalgia. And from the classification perspective, we can call it fibromyalgia.
I completely agree with Daniel. I think that not all post-COVID pain is fibromyalgia. So there are regional post-COVID pain. So when we discuss musculoskeletal pain, it's not widespread pain. I'm sure that many people will develop widespread pain similar with the diagnostic criteria than fibromyalgia. Sure. We are doing now a study on making the characterization of post-COVID pain with different tools for looking if they resemble the same feature than fibromyalgia. But I think that not all post-COVID pain will fibromyalgia. Some of them, yes. And how to treat? The same thing that Daniel, I think that there is no different mechanisms if a patient has migraine post-COVID or migraine because they have migraine. Because the cytokine storm is not new. Many post-COVID, many chronic pain syndrome has cytokine storm. Or not a storm, higher levels of cytokines. One example is fibromyalgia. Higher levels of interleukins, one of the reasons or one of the mechanisms for migraine. So the mechanism of post-COVID is not new. But the problem is that is new is the huge storm that is provoked by the COVID. By the mechanisms, AC2 has been studied many years. Interleukin storm or interleukins as promoting factors of pain also is clear. Interleukin is also clear. The question is why the COVID-19 make an explosion of any type of the symptom. So the treatment, I think, will be depend on the patient, and as Daniel says, is like symptomatic because we don't get any tool for the origin of the pain. But I think that post-COVID migraine will be treated very similar that regular migraine.
Okay.
aim is the same.
Okay, thanks, Cesar. Thanks, Daniel. So staying in the vein of treatment and how to help some of these patients, I think this one bumps back to you, Daniel. And yesterday's speaker, this comes from a colleague of mine in Canada, Dr. Roman Jovi, and he says that yesterday a speaker presented a study showing that 1 to 2 minutes of light activity every 30 to 60 minutes has increased cerebral blood flow and reported less fatigue on a questionnaire. So he wants to know, is this applicable to the observation of dysautonomia and cognitive impairment? And does this have implications for a treatment approach? And so how do you help those POTS and the dysautonomic symptoms?
So I do the classical stuff. First, you have to explain to them, because it's absolutely not intuitive to tell a patient that using socks or compression socks would help the headache or would help the fatigue. So we explain a little bit what the exercise that we can perform, staying on the tip of the toes, and the typical exercise we do to these patients. So elastic stockings would be the #1 thing. And then we very rarely, but I did this to a few patients, we use mineralocorticoids such as fludrocortisone, which is a drug that helps to avoid alterations in blood flow. One patient I had to go on midodrine, which is another drug we can use in this situation. So what I do is I check for dysautonomic symptoms on the bedside. I do the classical blood pressure laying down, and after 2 to 3 minutes, staying upwards. And patients will have no drop in the blood pressure, but have an increase above 30 heartbeats per minute. They're said to have postural orthostatic tachycardia syndrome. Some patients have no symptoms. Some patients have palpitations and mental cloudness. And if you treat them with these drugs that I mentioned, some patients benefit from propranolol, from beta-blocking agents, genetic beta-blocking agents. I do the basic thing, which is also good for migraine. So sometimes I use one treatment to try to target 2 problems. But I had the chance to, in several patients, I had the chance to measure the cerebral blood flow when they are laying down, and then they do they stand up, and that's so many alterations. Sometimes there's a 40% decrease, sometimes 50% decrease in the blood flow. And these patients would not say that they're going to faint or that they're going to have presyncope. They just say that they are a little slow, they're kind of cloudy, where they have this non-specific complaints of being mentally cloudy.
And so, the one thing I've noticed with some of the patients that I see that are struggling with the POTS, just simply standing, doing dishes, things like that, they can't even tolerate that. So if they're to do 30 to 60 minutes of, increased activity, is this standing? Is it lying down? What do you suggest to them?
I would suggest doing the best they can. Use elastic compression socks. It's extremely important. And try to add 1 minute every day. That's my practical advice. They say, I can only stand 3 minutes. I say, okay, do the whole thing, use medication, use the elastic socks, and try to add 1 minute every 2 days or every 3 days. But what patients usually can tolerate this small increase, and it's very beneficial. Of course, there's a huge discussion on POTS, because POTS co-occurs to several diseases. Some patients, so some colleagues are skeptical about it. And in some parts of the world, every fibromyalgic patients are said to have POTS, and POTS is the name they receive in places where fibromyalgia is a bad word. So it's very complicated to talk about POTS. But I think that some patients clearly have symptoms, and they clearly go better when you treat them specifically.
Okay. So there's a question that's dangling here, and I'm not sure anybody's going to hold you to this. I'm just going to put it out there anyway, but it's more of a general, and given, we are talking about COVID-19. So thank Jennifer Kirkwood, she said, thank you for sharing those articles and those studies. Any comments on patients with immunocompromised systems, not due to medication, but who have had adverse reactions to the COVID-19 vaccine? So she gives an example that, she's got a few patients that aggravated patients' chronic pain symptoms for about 4 weeks after getting the vaccine. And she says, I've been encouraging all of my patients to consider the vaccine, but now I'm being asked whether having the second vaccination is a good idea in those patients that have had aggravated symptoms from the initial vaccine. So she said she's recommended to her patients that they consult with their rheumatologist to discuss this further. But she's asking, has there been any studies comparing aggravated chronic pain reactions to vaccines in some of these patient populations? And I don't know, so I'm going to throw it out to you guys to ask you if you know, Cesar or Daniel, either one.
Yeah, I think that there is no specific study on changes on pain symptoms, either positive or negative after vaccine. I have two patients that they have a huge, very bad response with the first doses of the vaccine. She has 4 weeks with the same symptoms of COVID, so of pain, so it was huge. Now she's worse. So we are looking here in Spain, two different people that has improved in general the post-COVID symptoms, and people that is remember, or they are developing the same symptoms that they get with infection. Why, we don't know, to be honest. So I think the only thing that we can say is, this is the question, is we need to recommend to the vaccines, because it's the only way to starting again with the world. But the problem is why some patients respond highly positive to the vaccine, and why the others respond remembering the same symptoms that they get during the infection. We are looking also in another study, if people that are vaccine, but they are infected after with the COVID, if the post-COVID symptoms are the same or not that if they are not vaccine. So we are looking at the vaccine before the infection, because we are discussing now vaccine effects in people with long COVID. So they have been infected before. But we need to understand now that there are also people that now are vaccinated without being infected before, and they are infected after the vaccination. So we believe that the vaccine is a highly protective factor for future developing post-COVID symptoms. We don't get data now. We are starting with this study. But I think that we don't know why in some patients with long COVID, the response to the vaccination, either first or second doses, because also there is debate, can be chaotic, one or other place. I have seen both, so I don't know why, to be honest.
Yeah, and another, just to complicate things, there might be differences between the types of vaccines. It's a very tricky issue, but in Brazil, we had the first vaccine that we had is a classical vaccine. It's called Sinovac, which is a regular based on destroyed viruses. And we said, from the clinical perspective, there were much less reactions, and it's probably less effective as a vaccine too, that must be said, but much less reactions than we started to see after April of this year, when we started receiving RNA-based vaccines and the newer vaccines. So this issue may be extremely complicated, that is a first dose, second dose, third dose, previous pain aggravated, previous pain, de novo pain after the vaccine, and then the type of vaccine. So, and the last time I checked, I did this 15 days ago, there were absolutely no studies on vaccine and pain specifically.
For example, Daniel, the patient that get 4th week with symptoms was vaccine with the regular vaccine, not ARN, with the regular. So we don't know. So
yeah.
Okay, guys. So I'm sensitive that we've got about 10 minutes left here, and so one of the things that I'm struggling with in Toronto is these requests to see post-COVID pain patients and the long COVID patients in particular, and juggling our chronic pain population, our transitional post-operative pain population, and where are these patients going to land? And so, one of the things that I've kind of pushed some of my colleagues, my ICU colleagues, my internal medicine colleagues, is to come up with maybe a post-COVID plan or a clinic, or ask for funding to do something specifically for these patients, because there are going to be a lot of them. And they really need specialized services, multidisciplinary approaches, et cetera. And so I'm curious what's happening in your countries and your institutions, and how you're going about doing this. So each of you just take a stab at that, and I think we'll wrap up this session.
Well, in Brazil, there were some guidelines published by the government that are trying to follow, but so far we don't have any national initiatives to have specific post-COVID clinics. What we have is some university centers doing their own organization, such as we in São Paulo. Then we set up a clinic for, at least for chronic pain after COVID, but it's not on a national basis, not organized, not something which I would call a policy, a formal policy, unfortunately.
In Spain, it's the same thing. There is nothing from the government. Today, we are asking for a big grant for creating the first post-COVID multidisciplinary unit in Madrid, because I think that we need to be specific clinics when the patients arrive, and a good medical doctor. I don't know today which specialists can get probably the internal medicine, that I don't know. All the spectrum of the patients, and okay, I have more cardiac problems, go to the cardiologist, to the physical rehabilitation, cardiac rehabilitation. You have pain problems, probably neurological, if it is headache, something else, or rheumatologist, if I'm more musculoskeletal, and go to the rehabilitation. As physical therapists, I think that we are the last step, but the most important, because we can treat mostly, not all, obviously, but several of the symptoms. But for example, remember the discussion that Daniel has said about the autonomic symptoms. We are in front of a very huge problem, because we have patients with fatigue that we know that the only treatment is exercise or great motor exercise, but they have also tachycardias. They have tachycardias when they wake up. So it's autonomic dysfunction. We need that they are with beta blockades, but we need to adapt the exercise to beta blockades. So, we know that we are the last step, probably the most important, you understand, but we need to consider what is the patient that is in front, because not all patients with fatigue will be taking beta blockades for the tachycardia or the autonomic symptoms. A patient with fatigue can also cognitive blurring, and they don't remember the exercise program that she need to do at home. So we are in front of a new age, but I think that we need a first step, a medical doctor that identify the main role of the main issue of the patients. There are patients with 100 symptoms, so it's impossible. So, and to go into different pathways until the end. So we have a long way today.
Yeah, I think I want to echo what you both just said there, and the one piece, and you touched on multiple areas, cardiac rehab, but one of the things that I've seen in some of these very young patients that have been infected is the psychological aspects. So the PTSD, the anxiety, the depression, is this ever going to end for me? All of those things. So it really is going to take a multidisciplinary approach to help these COVID patients for years to come, it looks like to me. So I think at this moment, I'd like to thank the IASP again for highlighting this, and Daniel and Cesar for two fantastic talks. I certainly learned a lot, and I hope the audience did as well. And with that, I'm going to end the session. And I think my last plea will be a usual one, which will be, as Daniel, you build your center, Cesar, you do yours, we build something here. Let's talk about, what that data set should look like, so that we can actually, build something that's going to be helpful for, patients all around the world, actually. And if we collect similar data, we can certainly get to a place where we can certainly move things forward for our patients, which is always the goal. So thank everyone for joining us, and thank you both for fantastic presentations. And with that, we'll call the session to an end.
Thank you.
Thank you very much for the invitation.